was waiting for it this time. Our presentation topic today was a question that had been raised by the learning community here a little bit ago as we were planning out the curriculum. We thought this was a good time to get it slotted in to revisit. The question had been raised about the use of fluvoxamine and COVID-19. So fluvoxamine being one of our selective serotonin used quite as commonly outside of treatment for obsessive compulsive disorder. So we're going to look at the relationship between the two. I felt compelled for this lecture because everything I'm talking about is off-label. So just as an official disclosure, everything that we're discussing is off-label for the treatment of COVID-19. We're just really exploring some of the evidence behind some additional treatments. And as a reminder, I am a mental health pharmacist. I am not a virologist, so we'll do our best moving forward. Two things I wanted to do. We'll spend quite a bit of time describing the rationale for the interest in using fluvoxamine for the treatment of COVID-19. How did we even get there, recognizing that fluvoxamine may not be the front of line as we're thinking of antidepressant medications. And then we'll also discuss the evidence available regarding fluvoxamine's use in COVID patients. Full disclosure, I was a little excited when I did the first literature search for this. There were just over 30 hits that came back in PubMed, and I was like, great, we're going to have kind of a robust evidence-based discussion. As I went through them all, I realized very quickly that there are reviews that refer to one particular case report or clinical trial, and we will review that one at the end. But others really pulled from more laboratory data as well as some animal models that weren't specifically COVID-19 related. So we're going to pare it down a little bit and just focus on the one clinical trial that we do have with fluvoxamine, but talk a little bit more about why we got to where we are, because I think that's going to influence if we see more moving forward. Especially because I also know, even though Dr. Ballister wasn't on here, it did make me slightly paranoid because I know he's not a huge fan of the animal trials, so I did leave those off. All right, let's start at the beginning. So recognizing COVID-19, so the coronavirus disease, it's a single-stranded RNA virus. It is incredibly contagious. The highest risks appear to be in older adults, people with medical conditions, those who are pregnant or who have recently been pregnant. With the older adults, more than 80% of the deaths have been in individuals who are 65 years and older. There is a further differentiation even as you go through the decades, 60 to 69, 70 to 79, 80 to 89, and then above 90. There still is an increase in mortality. For those with medical conditions, there are quite a few that increase the risk for patients. Those who have cancer, who have any type of immunosuppressant medications that they're taking if they themselves are immunocompromised, other infections, things like HIV, tuberculosis, patients with long-term chronic illnesses, diabetes, heart failure, coronary artery disease, hypertension, lung disease, chronic kidney disease, liver disease, anemia, especially sickle cell anemia, patients who have a history of a stroke, those with mental illness, schizophrenia and depression, as well as substance use disorder have been called out specifically, along with some developmental disabilities, dementia. So a relatively wide group of individuals fall into that high risk category, and recognizing we don't have any approved treatments that are incredibly effective to eradicate this at this time, there's a lot of interest in what could we do to provide support for some of these patients if and when they do become ill with the COVID virus. The number of symptoms patients can experience, there's a huge range. It's been interesting. A number of individuals that I know have had COVID. I myself had COVID last year, and all of our experiences have been different. So in some cases, it may be loss of taste and smell and relatively few other things. In other cases, it may progress pretty significantly. So it really is variable, and it's a little bit difficult to be able to determine who's going to have which set of symptoms, which makes part of the clinical trial piece a little bit tricky, and we'll talk about how they were able to capture that. So recognizing that there are high-risk groups as well as a lot of different symptoms, we still are seeing quite a bit of mortality. This came from the Johns Hopkins website. My guess is I'm probably preaching to the choir to some extent with individuals recognizing this is a concern. So in looking at the fatality rate, these were observed cases per fatality. So they're looking at the number of deaths per observed cases in most instances. For a couple of the countries, they did have to use it population-based. So you see the United States is a little bit here in the middle, right about 1.9%. But what that 1.9% had turned into is 733,000 deaths when I pulled that just the other day. I don't remember if it was Wednesday or Thursday. So still a significant number, and this I believe was just through a portion of 2021. So something that's still an active concern for most individuals. So what are we able to do about this? I wanted to start, again, I'm not a virologist, but I wanted to start at this level because we are going to talk about some of the potential targets. So the picture on the left is a picture of the coronavirus. So the SARS-CoV-2 virus. These red things sticking out are spike proteins. And from the side, it doesn't look as much like it from here, but they have somewhat of a crown appearance, which is why they were termed coronaviruses, with corona being the Latin for crown. So these viral spike proteins are relatively unique to the virus and have been one of the reasons that this has been identified as a potential trigger. So for the virus, we're going to move to our graphic on the right-hand side here. The virus actually uses these spike proteins to interact with receptors on the host cell. It's able to get a handle and bind with the host receptor and then use some enzymes to be into the host cell. It can then release its information and start replication for the building blocks of new viruses. So anywhere along that pathway, lost my little arrow. Anywhere along the pathway, we could potentially interrupt this process to be able to impact the continuation of the infection. There is quite a bit of attention being paid, though, to the viral spike proteins interaction with the angiotensin converting enzyme 2 receptor, the ACE2 receptor, and that's where that big green arrow is pointing. So if the virus can't get into the cell, then it's not able to build new building blocks and replicate itself to continue the infection. So this has been one of the main target areas for treatment. So with that in mind, we do have a handful. This was just a nicer demographic. This came from a JAMA article. We don't have any library people on, but just officially, yes, it was right from there. But as you can see, there's going to be some targets specifically looking at the spike protein and the ACE2 receptor to try to prevent that. It's not the only place. We do have a number of other medications that are targeting other steps in the process. And potentially looking at starting to combine treatment so that we're trying to prevent entry into the cell and then maybe prevent the production of RNA or the instructions for the new viruses to see if we can get additional efficacy. But our focus for today is going to be on fluvoxamine. So where does fluvoxamine fall in all of this? As they were looking to try to target the spike protein as well as that ACE2 receptor, some investigators went to one of the national databases and they looked for medications who have documented activity for binding to those ACE2 receptors. Fluvoxamine happened to be one in that list of other agents. just briefly some of the agents we have available here. Some are chemical compounds that are used in other places around the world. So some of these, chloroquine, hydroxychloroquine, ivermectin, lopinavir, those may seem relatively familiar to you. Others may not, because they are used in practice in other places in the world, China, Japan, places like that. Our focus is going to be on the fluvoxamine though, and just for sake of time, that's why I'm not going to spend too much more time on those other agents. So looking and seeing that this whole list of medications are able to bind in those places, how well are they able to bind? So they did some binding affinity, they called it a bridge study to look at how tightly these medications would bind. We found that in that whole list of compounds, fluvoxamine kind of fell in the middle for its binding capacity, both at the ACE2 receptor as well as at the spike protein. So something that is going to get in the way and interfere, but may not be the tightest binding. And in this case, they're negative numbers, but the greater the negative number, the more tight or greater the binding affinity. So for the ACE2 receptor, lopinavir actually had the greatest binding affinity. And for the spike protein, the ivermectin actually had the greatest binding affinity. So our fluvoxamine was a little bit in the middle. So maybe not a huge surprise that it hasn't taken off extensively in terms of a treatment of interest. But there's been a lot of discussion about fluvoxamine and the fact that in addition to its activity at the ACE2 receptor and the spike protein receptor, it does have some agonist activity at sigma-1 receptors. So sigma-1 receptors are receptors that can be found on the endoplasmic reticulum. So within the cell, in the mitochondria, which are kind of our little workhorses within the cell, these receptors reside there, and they play a pretty significant role in oxidative stress. There have been polymorphisms in the sigma-1 receptor that have been associated with Huntington's disease, with Alzheimer's disease, with Lou Gehrig's disease. So it appears to play a pretty significant role, especially neurologically, in the oxidative process. So by increasing the amount of activity that the sigma-1 receptor has, it's thought that it may be able to diminish to some extent the inflammatory response, which may then prevent additional damage and problems related to the COVID-19 infection. Part of this is based on an animal study. I hate to say that, but it was based on a mouse study. So they looked at mice that were put into a septic, into a clinical scenario where they were septic and they were injected with fluvoxamine. They looked specifically at activity at the sigma-1 receptor. They saw increased activity here and did see an improvement in those patients who received the fluvoxamine injection versus those that received the placebo. So the thought was maybe this can also interfere in part of the inflammatory process that's happening. One of the other suggestions that's been floated is, for the record, they have not done specific trials looking at measuring melatonin levels in COVID patients, but fluvoxamine is a known enzyme inhibitor. It inhibits cytochrome P450, 1A2, and 2C19 pretty significantly. Both of those enzymes play a role in the metabolism of melatonin. Patients who have higher melatonin levels do seem to be higher melatonin levels have been correlated with improved response or less severity of symptoms in patients with COVID-19. I'm not saying it treats them, but it just seems that patients who are doing well did tend to have higher melatonin levels. So the thought is maybe this could be another way where fluvoxamine may be beneficial. So all of these considerations went into the pilot study that was done for fluvoxamine. So big buildup, but kind of why did we get here? Because it seems like a random drug to have here. This was a pilot study, essentially. It was a small randomized double-blind placebo-controlled trial. They were adults that had confirmed COVID-19 infection. They had to present within 7 days of symptom onset. So whenever their symptoms started, regardless of when their test was, the test had to confirm that they had it, but as long as their symptoms had been less than 7 days, they could be enrolled in the trial. They also wanted to ensure that a patient's oxygenation saturation was 92% or above. So essentially that they were still able to exchange oxygen pretty well, so that they weren't already having difficulty. So mild to moderate symptoms was what they were really targeting. The patients that they included were, just a second, were patients who were in their mid-40s. There were significantly more women than men. It was about a 70-30 split. Most of the patients did have at least one medical condition. So diabetes, hypertension, hyperlipidemia were all common diagnoses that the patients had. Asthma as well. They were split into 2 groups. Everything was done remotely. So patients were sent out a pulse oximeter for them to check, as well as a sphygmomanometer to check their vital signs. And then they were given some screening questions as well. All of the interviews were conducted via Zoom because the patient did have active COVID infection. The medication was also sent to them remotely. They were in one of 2 groups. So they were either given fluvoxamine or they were given placebo. For the patients who started on fluvoxamine, if they were deemed eligible for the trial, they started on 50 milligrams day 1. Day 2, they took 100 milligrams twice daily. So they jumped that dose up pretty significantly for days 2 and 3. And as long as the patients could tolerate it, starting on day 4 through day 15, they took 100 milligram fluvoxamine 3 times daily. So for a total of 300 milligrams a day. The primary outcomes that they were looking at were clinical deterioration. So there was there's a rating scale that was designed by the World Health Organization that looks at clinical deterioration specifically for COVID. And it asks about a whole number of symptoms. So presence to absence of symptoms, I believe it was a 0 to 7 rating scale. They were looking specifically for new onset shortness of breath, with or without hospitalization. So if that had happened and we see an increase in the rating scale score, that would mean the patient's symptoms are getting worse, even if they didn't hit the threshold of requiring hospitalization at this point. They also were looking at the oxygen saturation, and they wanted all of the patients to remain above 92% on room air. What they found, so they found that 0% of the patients on fluvoxamine had what was considered a clinical deterioration, while there was 8.3%, so 6 patients total in the placebo group that did have that clinical deterioration. They were the ones that saw a change in that clinical status scale, the rating scales that was developed by the World Health Organization. Most of the changes were related to breathing. So where patients were having more difficulty breathing, they were increasingly short of breath, they had increased cough. That's where most of those symptoms came from. There were a few, I believe it was 2 patients that had some increase in muscle soreness, headache, and in other areas, but most of the change in the scale was breathing related. 1 patient in each group required hospitalization, possibly due to their COVID infection. For the patient in the fluvoxamine group, the main chief complaint at hospitalization was a headache. So possibly, so there wasn't really a difference there. And then in terms of tolerability, 15% of each group did report adverse effects. Although I thought it was interesting, most of the adverse effects were pretty consistent with symptoms you could see with a COVID infection. The most commonly reported were pneumonia and shortness of breath for both groups. For the fluvoxamine group, they also had headache, nausea, vomiting, and muscle aches. For the placebo group, they also had decreased oxygen saturation. So when they were falling below that 92% threshold, chest pain, fever, and nausea and vomiting. So quite a few adverse effects were identified, although it's not totally clear that it was due to the medication or the placebo versus just the infection itself. So in looking at this, there was a little bit of a difference in the clinical deterioration. So patients were relatively healthy. They were fairly young. So in terms of those high risk groups, that's not necessarily the population that was targeted here. They were treated just for 15 days and they had to start treatment. They were only eligible to start treatment if their symptoms had been present for less than a week. So really trying to start this early in therapy. They didn't necessarily look at some of the other findings. They did follow patients out after the 15 days. They did a 30-day check-in to see if any of the patients had required an emergency room visit or hospitalization. And there were none in either group that did require that. So possibly this may be helpful for some of the patients. It's the only clinical evidence we have at this point. There is quite a bit of interest in having additional clinical trials reported, even if it is retrospective in what individuals are using out in practice, to be able to get some additional data to see if this actually would be effective. Because it was 6 patients in the placebo group. They were about at the same severity of symptoms at baseline. So maybe, but it was a relatively short time frame as well as a small patient population and not one of the high risk ones. So while fluvoxamine does have some pharmacologic activity that would suggest that it could be beneficial, we really are only at the preliminary stage for saying maybe this could be helpful in the treatment of COVID, but nothing that's solid enough to be able to say absolutely we can start this in patients moving forward. So with that, I will stop my share and turn it back.